This is the postgraduate pediatric orthopedic video series. I'm Sattal Shraid. I'm a pediatric orthopedic surgeon. In this video, I'll take you through how I do hip arthrodiastasis using articulated hip distractor. And this is part of chapter 4 of the postgraduate pediatric orthopedic book. If you recall from the very first video in this series, we covered what Perthes disease is, the classification, the approach, the treatment, and the outcomes. We also covered various types of treatment and the evidence behind them, including physiotherapy, brace, cast, femoral osteotomy, pelvic osteotomy, shelf acetabular-plasty, combination of these, and hip distractor. In another video, we covered how to perform femoral osteotomy for a child with Perthes disease. And in this video, we'll cover how to do hip distractor. There's ample evidence that hip distractor is useful in late onset Perthes disease, particularly in children who are older. This paper about the articulated hip distractor showed good results. Jamal Hosni from Egypt showed non-articulated hip distractor is equally effective. In a systematic review and meta-analysis of efficacy of hip distraction in Legg-Calvé-Perthes disease, Al-Sagar reviewed around 16 papers using various forms of hip distraction, including hinge and non-hinge in elderly children, and he showed some benefit, more than non-treatment. That's why we use hip distraction in some challenging cases, particularly elderly children above the age 10 or 11. As we did with all our previous videos, we base our operations on real-life scenarios. This is about a 12-year-old boy who presented to us with hip pain. His x-ray showed the sclerosis of the femoral head, and the lateral showed some subchondral bone collapse. His blood tests were normal, and his MRI scan was consistent with Legg-Calvé-Perthes disease. After consultation and consenting for the surgery and finishing all the logistics, we took him for theater for application of hip distractor.
There are multiple hip distractors in the market. The one I use is the Orthofix one, which I find very useful and very versatile and make the procedures much easy. And it has many features that help with the objectives of the procedure. You have the pelvic component with multiple holes for half pins. You can use this one to attach it to the pelvis, and you can tighten these screws once you put the half pin. Also, you can use the same device to make a ring or a hole to get the anterior pin, should you want that. Then this is attached to the polyaxial hinge, which allow abduction, adduction, but also it allows some flexion extension. Below it, you have the flexion extension component, this one here. And at the bottom of it here, where this hole is, this is where we put the wire for the center of rotation of the hip. And if you notice, there's some slopey element to it, which is really important if you don't get it perfect. If your K-wire is not in the perfect spot, so still allow some movement here. Here we go, there's a sliding component here. This sliding component is to distract the hip further if the initial distraction is not enough. And after a while, when the pins become loose and if they are walking on it, it might become compressed again, so you can distract them again. How you distract them is by this distracting device, which you can fit it to the hip distractor, and you can click it in this way, and you can use this Allen key to distract, as you can see here. I'm distracting it, and you check with X-ray whether you have 2 or 3 millimeter joint opening. Once you finish the distracting, you need to lock it, otherwise it can't compress again. So this is locking it here. Then you go below, you have another polyaxial hinge, and you have the femoral component here, and you attach this to the femur. And once you attach it to the femur, you can lock this polyaxial hinge. So this is, now you locked it. So this is simply the distraction device I use and I prefer. Now we're going to see how we apply it on a patient.
This is our patient we described earlier. We brought him to theater. We positioned him supine on radiolucent table. Private parts are covered with any kind of dressing. And we do EUA. As you can see, there's hip adductor tightness, and with eye of faith you can see how the pelvic is tilted toward the left side, indicating some contracture of the hip on the right side. We need access for the hip adductors, so we prep this area with the chlorhexidine and we apply iopan so that it will secure the private area coverage while allowing surgical access for the hip adductors. So we put iopan on one side, then we secure the other side with the iopan on the other side. We started preparing the patient. We start from the foot and going upward. We clean the surgical field. I prefer using chlorhexidine because the evidence is mounting that it is superior to the iopan. The very nature of this procedure requires access to the back of the buttock. That's why I told the patient and the leg toward one side to prep everything behind the buttock. Then I use a utility drape or any draping behind it. Then I'll flip the leg back to allow access for the inside of the leg. Again, I prepare it using chlorhexidine and make sure that no area left unprepared. Once I'm happy, we use our U-drape, and again we prep. We stick it in a way that we can get access to the very back of the buttock, as you can see here. And then we put a large utility drape on the top and stockinette for the foot. Again, there's evidence that for any hip surgery, if you don't prep the foot, the risk of infection goes up. One last bit is that to secure the edges of the draping to the skin using iopan. We did the inside, then we're doing the back of the hip as well. And this allows your drape to remain really attached to the skin and kind of secure the surgical field from any contamination. We connect our diathermy and suction, but also we do the second preparation. And this is standard in my practice, that always when I finish my prepping and draping first time, I'll go again. I will use a chlorhexidine to prep the skin just before I start the surgery. At this stage, I will start marking my bony landmarks and my surgical incision. I don't do it before this step because if I do it earlier, the second preparation the marking may disappear. That's why I leave it to this stage. My X-ray machine come in to help me with identifying this bony landmark. Here I can feel for the greater trochanter, my thumb on the greater trochanter. Then I use a K-wire to mark my neck of femur. The first part of this procedure, I usually pass multiple drilling through the neck just short of the physis. Some people cross the physis, and the evidence behind this is still weak. However, more and more studies coming showing it might have extra advantage. So this is my first part of the procedure, passing multiple drilling through the neck just short of the physis. If you want to cross the physis toward the necrotic area, it's okay. And this is like hoping that to stimulate bone healing and bringing more stem cells to the necrotic area. And this should be done under X-ray control. And as you can see, my assistant putting some saline to cool the drill to prevent cell death from the heating process. Once I'm happy I've done multiple drilling, I go to the application of the Hip Distractor. The first and probably the most important part of this procedure is to get the K-wire at the center of the rotation of the hip. Here it is from the tip of the greater trochanter to the center of the femoral head, as you can see on this X-ray. And this wire should be both at the center of the femoral head, both on the AB and the lateral view. So once I'm happy with the position of this wire, which is the center of the rotation of the hip, I assemble my hip distractor on this K-wire. Here I'll pass there's a special hole as we've seen earlier when I described the hip distractor, where this K-wire is fed through this hole. Then the pelvic part is stabilized to the hip using K-wires. Usually they're 2.5 K-wire threaded tip. So we fix it temporarily to the pelvis and to the femur with another K-wire. So our hip distractor now is fixed to the femur and to the pelvis, centered at the center of the rotation of the hip using wires only. Then we start to putting our half pin. We drill the center of the top pelvic piece, then we measure it, then we put our first half pin. I usually prefer half pin in these areas. So we put our first half pin, then simply we replace all the wires with half pin. Of course, apart from the center of the rotation wire, this is just for guidance only. Assistant keeping the distance from the skin because we don't want it to be too close to the skin, and I use HA coated half pin. This we put the first half pin, and make sure that one of the half pins stay broad, because later we use a threaded rod to prevent hip flexion contraction. I'll show you at the end of the video what I mean by that. Then next we move to the second half pin. Small stab incision on the skin around the wire, then a blunt dissection down to the bone. We try to move as much as soft tissue away from our track. Once we are happy, we reach down to the bone, we remove our K-wire. Then we use a drill. Depending on the size of the half pin, your drill size will be decided. These are 6.5 half pin, and usually the drill is 4.3. These are HA coated pin, so they integrate well with the bone. If you're using smaller, for a smaller child, you can use smaller half pin. But in general, usually these done in children around age 12 and above. So 6.5 usually good enough. So now we go with our drill. This is all done under the X-ray screen, so that we don't go deeper than we should. Of course, you can rely on the feeling of your drill and the screws when you penetrate the first cortex and medulla, then the inner cortex. But this is not a replacement for proper visualization using the fluoroscopy. Here we finish the first pin, then the second half pin. Now we move to the third pin. Exactly the same sequence. First we stab the skin, only the skin, then use a blunt dissection down to the bone. And once we are happy, we removed all the soft tissue from our way. Either we can use tissue guard, or we can use oscillating mode, the drill in oscillating mode. We remove the K-wire, then we introduce our drill, and we go through oscillating movement through the outer cortex and the medulla, then the inner cortex, and of course with the X-ray screen. I cannot emphasize the importance of the X-ray screen. Then we put our half pin, and this once with the half pin in, we tighten the pelvic piece to our half pin, and this will fix or will stabilize the pelvic component to the pelvis itself. Here I'm checking the X-ray. I'm slightly advance a bit more because still not protruding. I want to see 2 mm on the inside cortex. Then we move to the femoral aspect. We adjust the femoral component to be parallel to the bone. Then we do exactly the same, small stab to the skin, then blunt dissection down to the bone, remove the K-wire and drill the cortex, going through the outer cortex, medulla and inner cortex. Of course, you can measure the width of the bone to gauge the length of the threaded part of the half pin, but this is not always necessary, because even if you have a HA coated part sticking outside the skin, recent studies show this can be useful. But I usually use around 30 to 40 mm threaded part, depend on the size of the child. Here we finish the first half pin, then we move to the second one. Again we use a guided wire, rest it on the bone, stab to the skin, then our drill. Here we can use one of the oldest tricks in orthopedic, where we don't need to get lateral view on the femur to ensure that we are in the middle of the bone. Because of the middle of the bone is like a cylinder, if we put the threaded tip, so the threaded tip rests on the lateral without overlapping with the bone, this means we are truly in the middle of the bone, so we don't need to get a lateral x-ray. This little demonstration demonstrate what I just said. If you look at the bottom picture where there's circle, which is the bone, you can see 3 tips of a drill. The one in the middle, because exactly in the middle of the bone there's no overlapping with the bone. So in that case, once you see your drill tip is not overlapping with the cortex, you're in the middle of the bone, so you don't need to get lateral views. And here we finish with our first half pin on the femoral side. We moved with the second half pin, again exactly the same process. Basically a stab around the K-wire, then blunt dissection down to the bone, then drill, then put half pin. We speeded the videos here for the sake of time. Again, you can see here the wires removed, then drilled to the other side. Of course, this is in the X-ray screen. First cortex, then we are through the other cortex. Then we put our last half pin. Now we finish with all the half pin. We tighten our frame to the half pin, and once we are happy, we remove the initial wire that put as a center of rotation. Then we apply our hip distractor. Before we put our hip distractor, we need to loosen the screws on the side to allow the sliding mechanism of the frame. Then once we apply distraction, and we see how the hip opens under the X-ray screen. And we need around 2 or 3 millimeters extra opening of the hip, because usually the joint space usually around 2 to 3 millimeter. We need to add 2 millimeter to that, as you can see in this picture. Again, once we are happy with that thing, we tighten the side screws to lock the sliding mechanism, because you cannot rely on the threaded mechanism to keep it distracted. Then we check the range of motion both for the hip and the knee, because the femoral screw, if they go through the IT band, they might restrict the knee flexion. This is another view to see the good range of motion we got in the hip and in the knee. As you can see, is the hip really that moving, not the pelvis. And the last thing is there's a small mechanism we add to this hip distractor to prevent flexion hip contracture. Usually you can do during the procedures or on the ward, it depends on your preference. Here we use 3-hole rancho attached to the femoral and pelvic component, and to that we attach a clamp, and this clamp should be mobile and rotate, but it should not come out. And we use a threaded rod with 2 knots in the way I'm showing to you now, and these we can slide it through these things, and we move the knot to the end, so this would lock the hip. It doesn't prevent flexion, and we advise the patient when they sleep they should keep it in fully extended position. And this is really to combat the common complication of the hip distractor, which is a flexion contracture. When they wake up in the morning the second day, they can remove it and they start exercises, which is flexion and extension exercises, as well adduction and abduction exercises. And this is really essential part of the rehabilitation program. When we remove the frame, this is the picture 3 months after we remove the frame. As you can see, it is Stulberg type A, modified Stulberg type A, which is really very good for Perthes disease at this age. On the lateral, you can see a little bump, but this is really minor given the fact that poor prognosis for Perthes disease in elderly children. This will take us at the end of our video. We hope you find it useful for your practice and for your exam. On behalf of the postgraduate pediatric orthopedic editorial team, wish you all the best.